what are we looking for going forward 10 years from now? What is the future of Lyme disease management? Will there be testing improvements?
I would think eventually
Absolutely.
you get more, you see a trend towards more DNA-based testing platforms that may evolve. I think eventually there would be better testing that would help. The question of vaccines, that's been something that people have been struggling with for a long time. And one interesting thing is vaccines against ticks themselves. Because if you just, there have been a lot of problems with the vaccine so far. I think that of those different things that are being considered, that's probably the best option. So it's been very hard to develop a vaccine, just like a vaccine against a common cold. It may not be possible. I would love to see it happen.
The problem, one of the major problems is that even if you had a good vaccine for Borrelia, what do you do about the co-infections? And more and more ticks are
And that's why you're
co-infected.
going back to your anti-tick. There's a wisdom commonly shared, and that is that the more erythema, the more redness and inflammation you develop at a tick bite site, the less likely you are to actually get infection.
More robust
And
immune
so
response.
that goes back to your comment. If you could come up with a tick saliva vaccine, not only would you cover Borrelia burgdorferi, but you'd cover co-infections as well.
I also think there's a trend towards looking at the microbiome, the tick microbiome, the human microbiome, and that's part of disease. And it's not like you can ever just get rid of all infection in the body. It's the microbiome that's within us.
All right.
And that's, I think, being a broader area in psychiatry and general medicine with chronic illness to look at chronic infections, and the microbiome and some of these infections are good for us.
We're
They're
going to
not
get
always bad.
guideline changes going forward?
Yes, I think we need to get guideline changes. And the reason that we need to is because even though I know the IDSA is coming out with their guidelines in early 2018, my understanding is they didn't last time, and I'm guessing that they won't this time, include anything for patients with chronic disease or post-treatment Lyme, whatever you want to call it. And so that is very problematic. The same way with the CDC MMWR article, the way they have totally in a little box in the side of the article put in that they do not recommend any antibiotic treatment or and IVIG treatment for chronic Lyme, because of course we know chronic Lyme doesn't exist. So now you leave a whole plethora of patients out there without having any kinds of options. They're not allowed to have alternative medicine. They're not allowed to have extended antibiotics, which is not an alternative medicine. I mean, tuberculosis patients get treated
And
2
there's a
years
reason for that,
for
Pat.
IV antibiotics.
There's a reason for that, and that is that is the lack of really rigorous science in support of those approaches.
I agree with you. I am
So-
favorable
so
to
you know
it.
what? Hold
What
on.
I'd like to see is
Well-
what I'd like to see is cooperation between the two ends of the spectrum, proper studies,
I'm totally
proper
favored to that.
studies.
Okay, well, I'm going to stop right here. I'm going to go around and everybody's going to get a last word. You're going to get it too. Dr. Bransfield, start.
Okay.
This is your shot.
Sir William Osler, the father of medicine, once said, to know syphilis is to know medicine. But I think we could look at that in terms of Lyme disease, and to know Lyme disease, you really have to know not just medicine, psychiatry, entomology, epidemiology, immunology, psychoimmunology, rheumatology, politics.
So cardiology in as well.
Cardiology, you need a broad capability that's beyond the training of most people. So the big thing we have to have is some humility. We can't have arrogance. We have to know that a lot of the answers to this are outside our field especially. So we have to have open dialogue, open communication like we're having here, and that's what will help resolve this.
Dr. Shor.
Well, it's important, I think, to recognize from my standpoint that chronic active Borrelia infection exists. What is most contentious is this post-treatment component, which I'll get to in a second. But what is often disregarded are those who never get diagnosed, and it's untreated. And the fact that we have an expanding tick population, the percentage of ticks are increasing that are actually infected. The majority of patients never recognize they've been bitten by a tick. There's a large percentage of them that don't have the hallmark feature EM rash, and if they do, it's often in a hidden place, or it may be atypical. They present with common symptoms, the summer flu, then throwing in the post-treatment group that can potentially present in similar manners with chronic disease, we've already alluded to there's good evidence of persistence after requisite antibiotics. Not everybody who's chronically ill after treatment has active infection, but I would argue that a modest percentage. And so that we need to be empathetic in dealing with these chronically fatigued, chronic pain, cognitive impairment, this complex of individuals who, unfortunately, because of poor lab testing and the politicization of this condition, are often peripheralized.
Dr. Sigal.
In clinical medicine, an open mind and an open heart. To sort of rephrase what you were saying, we have to have humility, absolutely. We don't know everything. We have to be open to the possibilities of it being Lyme disease, being another infection, being something else entirely, being immune-mediated or inflammatory-mediated. You have to be aware of all the potential mechanisms, and you have to be humble in the sight of all these competing potentials. You have to have an open mind, and ultimately, even if I can't make a diagnosis, the person who's sitting in front of me is suffering. Mm-hmm. And to show that person the door without any sense of what we're going to do next is cruel and should not be the practice of any physician. So open mind, open heart in clinical practice, and better science. We need to stop arguing with each other, and we need to stop pointing fingers at us. And we need to be able to move on and say, ultimately, the only important thing is that patients are suffering. Ego, I agree. Power, I agree. Money, I agree. We have to throw out those things and get beyond ourselves and sit down and come up with the studies that will allow, mutually agreeable studies that will allow us to come up with biomarkers, better seroconfirmatory tests, they're not diagnostic tests, seroconfirmatory tests, better approaches to therapy. Anything short of that is an abdication of our primary responsibility, which is to practice scientific and empathic medicine.
And I promised you the last word.
You did.
And I'm keeping my promise. Go ahead.
I want to speak to the fact that for many decades now, patients and advocates have been left out of this process of Lyme disease. And by that, I meant they've been excluded. Other diseases have had committees for years that have sat in Washington, and they've sat on these working groups, and they've been able to have input into their disease. Patients have been totally excluded. It's very frustrating for them. It has caused, in my opinion, some of this bad science, because the patients really know, educated patients know what kinds of studies that they need to help them with their disease. They just want to get better. They don't care about these arguments. They want to get better. They've never been able to sit down. So finally, I'm pleased to say that last year, we were successful for the first time, after a lot of opposition from the IDSA and others over the years, to get legislation passed and included in the 21st Century Cures Act that provides a working group. That there's a working group now in Washington that only includes federal officials at the table. They have been making all the decisions for patients. I mean, that is really outrageous. And so now patients, because of the way we set this up, will have a seat at the table. Perhaps advocate or a member of a Lyme organization will have a seat. Our treating physicians who have never had any input into this process. And guess what they're going to be doing? They're going to be working with all the different agencies to find out what are the research sources that are available for research? What kinds of studies need to be done? And guess what? It's also going to be done in a transparent fashion, whereas now it's behind closed doors. No one knows what research is selected until after it's done, and then you have no say in the matter. So I just say for Lyme patients, the time has come that they will get a seat at the table to be able to have input about their disease.
All right. Well, thank you all for being here. You can all take off your flak jackets and your helmets. This has been A tremendous discussion, one of the best in my career. And I'm glad we all got in the same place at the same time to discuss what has been one of the most contentious issues in modern American medicine. On behalf of our panel, I want to thank you for joining us. And I hope you found this peer exchange discussion to be useful and informative. I'm Dr. Peter Salgo, and I'll see you next time.